Okay, it says for me to let everyone know that they are being recorded and transcribed. So yes, to attend, so that they can see the conversation and participate in the next call. So I'll go over the ground rules for people to stay on mute unless you have something to say. Don't put us in if you're on the phone. And then also to use the raise hand feature, so that we can kind of, keep things organized in the chat if you have things to say, and I will call for people to come off of mute on the phone so that they can speak as well. This call is to help you and your patients, and your residents. So feedback is boots on the ground. These calls are very hard to have if people don't speak of their experiences and the information that they would need to make the transition of a patient better. So please utilize the floor. The next point is to be respectful. We are and develop solutions, not to place blame. And I think that's all I had. So those are the ground rules. From the SNF side, we kind of polled them. Brett spoke with them to just kind of share some of the challenges they faced when patient. So the top 4 that they had were imprecise or incomplete referral information, perceived without holding perceived information, delays in receiving required information, and poor timing of transfer and receiver. From the hospital side, their main challenges that they face are unclear criteria for SNFs not accepting a patient, confusion regarding colonized or active infections that would impact acceptance of patients to a SNF, and also poor timing of transfer between sender and receiver. So if anybody from the SNF side or hospital area where you received incomplete information and this inhibited your ability to either discharge, well, this needed to accept a patient, I think that would be helpful to understand what type of information you need to receive a patient, and then how that impacts you when you don't receive that information, but you. So do we have anybody from a SNF that can come off mute and just kind of share? And I'll go to the chat just in case anybody is talking there. You don't have to name facility names or anything. Just it's helpful for the.
Hi, Commissioner. This is Julie from College Park.
Go ahead.
Can you hear me?
Yes.
Okay. You said come off mute. So I'm sitting here with my team, and basically some of the things that you went out on the outline are very true. I think we're all willing to take patients that are difficult, and we know that the diagnoses and things are different on the patient we see today than from before. So I don't think that's behaviors, things like that. We certainly need to know, but I think things are hidden because of that. And again, I can only speak for College Park right now, but I know they also come clinically very, very unstable. So it feels like if we send them back, and we clearly do try to keep them and look at them and work with the physician, I can say that honestly. So if they end up going back, it's because they truly need acute. Example being, let me give you a concrete example. 2 nights ago, we accepted a patient, and a patient came in, and we knew there was some pulmonary issues. We were prepared, everything was fine. Patient arrived completely different, and I believe we were looking at a 90% stat at 12 liters. We could not stabilize this patient. Clearly, we couldn't even bring the patient in. She couldn't breathe. We sent her back, and the notes that came back said, made it sound like College Park was incapable. That patient was at risk and should not have left that hospital. I don't want to, be negative about everything, because majority we do get are good, but there is still a very, very large amount that come in here very unstable.
Hi, this is
Right,
Judy
thank you.
Gamoy from Ormsby Post Acute up here in Carson City. I would agree with that. We're having similar challenges, and very often what we're seeing is we will accept a patient based on the criteria that's in the referrals. And then once the patient is get here, the discharge summary is completely not reflective of what we accepted. And then there's things in place that we clearly can't manage in this setting. So we're scrambling around trying to manage it. And very often, sometimes have to send them back because they're not stable or appropriate for our setting.
The discharge information and the summary on the patient, who does that come from?
The discharge summary comes with the patient upon admission. And the hospital will typically release those documents.
Uh-oh, did you stop
Patient at that
talking or?
point. So, a lot of times we have our hands tied because we've already accepted that patient and we don't want to squelch any kind of relationship we have with the hospital by saying, wait a minute. So a lot of times, we take them and try to do the best we can, and then ultimately they end up going back.
So, in reference, is there any you receive prior to admission information that's collected where they kind of just go through the patient status, that you all would need to know prior to? Do you know if that's happening? To make sure that you have all the information you need before receiving a patient and making sure it's within the scope of work to handle a patient of.
I'm sorry, I missed a lot of what you said. You were cutting out.
Oh, goodness. Can you hear me now?
Yes,
Or
ma'am.
am I still choppy? I'm saying, I know one of the things that we've discussed form so that you can, or some type of form that has all of the information that you need to assess to make sure that you all can truly take care of that patient. Do you know if anything like that is being used by your staff to collect information from the hospital? For those from the hospital, is there a form that you all send out that would have that information, or is it just kind of everything is in the record and the
We're being told, because
information?
the basis for accepting a patient comes within the referral. All the information that we need to know to accept and make that decision comes within that referral. A lot of times the referrals are very, very light and we have to send it back and ask for more information. However, the hospital is very reluctant to give us any information until the doctor writes that discharge summary. So we're very often, forced to make a decision, yes or no, based on the referral. And then once we've accepted, docs will often, change what was in the referral and change things in the discharge summary. And we've already accepted at that point.
Judy, this is Jen Connolly. Just a quick question for you. Your admissions coordinator at your facility or at any skilled, are they clinical, or are they receiving this and going off of a standardized form that you have internally for acceptance?
I can't speak for all facilities, but our admissions people are not clinical, but our corporate office is wonderful, and they have provided a red light, green light system, which they follow. And if there's anything in there that our admissions director isn't sure of, he is really good about bringing it to the director of nursing and myself for review. And we go off of that. But it sounds like, Kamisha was referring to a form that we use once we've accepted and we're waiting on the patient to get here, our nurse to nurse report. A lot of times we're running into the hospital isn't calling report to us until the patient has left the hospital and is en route.
This is Michelle from Harmony Manor in Winnemucca. I find that the exact same thing. I'm a DON here and I review all of the referrals that come to us. And a lot of the times, like they said, it's either light or it is, say it's sent on the 20th, but all the notes stop at the 18th or things like that. So we do a lot of calling and asking more questions and more information. I find that they get pretty irritated with us for asking those types of questions, but as the other ladies have talked, I completely have had that experience. They get here, they might be great for a discharge from acute setting or the med surge, things like that, but they're definitely still not appropriate for our skilled or rehab services, long-term care. They're still a little bit too sick for us. And that's kind of smoothed over, or we feel quite a lot of times is, that they do send us things that, well, you're incompetent to take care of them then if you're not accepting them, or, you can do this. And really we can't with the resources we have. Even us attached to the hospital, we end up having a very lengthy conversation with our hospital people that we get sent over and have made a good relationship with them. But as for outside facilities, it's really hard to not sound like we're just refusing all of them, but also letting them know that their acuity is still too high for us to take care of.
I see that Gina has her hand up.
Oh, thanks,
sorry.
Gina. Gina, you have the floor.
Thank you. I appreciate it. Good morning, everyone. I have a quick question because I've heard the term a couple of times. I don't want to assume when in the communication relative to what I'll refer to as the quote unquote hard handoff, when you say it's a little light, am I correct in that you do not have or have not received the full clinical picture relative to the documentation?
That's correct.
Correct.
Okay, thanks. One other quick question dovetailing into that. I'm regional with the Valley Health System, and I do know, respective to the operations that we perform and provide in our collaborative network with our post-acutes, when a referral has been submitted, there are liaisons. I may be not using quite the correct term, that typically will come on site and or reach back out to our teams to do additional evaluation to determine and understand, to your points, is the patient, we start discharge planning on day one. And yes, I feel your pain in that we start the process, and on what I refer to as D-Day, the patient's going to be discharged and things have changed. Now, the impetus with making sure that it still would be a safe transition of care out of the acute is, on us. I'm just going to say it, and we need to watch that. But, are there liaisons like I'm familiar with some post-acutes that will come on site and or reach out and have that day of discharge discussion, or they evaluate or speak with the patient?
Hi, Gina. It's Bob over at Harmon. How are you?
Hi, Bob. Good to hear you.
Good. Yeah, we do have liaisons out in the field. Not with all hospitals do they have access to go up and do some, direct evaluation. That said, obviously yours is a little bit different for us. But I would say, just in the manner of collecting and gathering, the necessary documents for post-acute placement, there is kind of a time lag. I get the urgency to sort of move forward and post the patient's face sheet online, and then we're chasing down documents. In the world over here, where there's hundreds of referrals kind of coming through, we're going with the first clean packet to sort of move the patient, and sometimes that jumps around a bit. Oftentimes patients have a change in condition and we see that, or, all of a sudden there's a patient choice in the mix, and we have to kind of move around that process a little bit differently. But for the most part, the clean packet timeline, it, it's more than a day in most cases, and really we just want a clean packet right out of the get go. I think the hard handoff and calling the facilities is is a bit confusing because sometimes, often the discharge summary is different than what the patient looks like, and have been discussed when they arrive. I don't know. Others may have comments about that, but
No, and
obtaining all of the basics is that can be frustrating and causing probably more calls than what we need. If we can get it straight out of the queue, that I think would help us move quicker.
And thanks, so Bob. And I think you're spot on. We recognize communication came my way, gosh, maybe a week or two ago, relative to the referred to as a portal that VHS uses to submit referrals. And that, in fact, I recall I was speaking with one of the contracted payer groups, and they were saying that, again, there was some experience relative to quote unquote the clean packet, and that everything that was needed was received. So, as you well know, when we hear about that stuff, I hear with my leaders for Valley, we jump on that. And I do have our corporate partners with CarePort, is what it's called now, looking into what's happening with some of these documents missing, because it's it's artificial intelligence. It's identified and flagged relative to those integral elements of the chart or the EMR that need to be provided in the referral. So we're looking into that for sure, realizing it's probably that time again to reevaluate what's provided and what's not, because I know you'll recall years ago, the communication was that we're receiving, 8 inches of chart, and we don't want that.
Yeah.
So so it might be the time again to say, okay, this is what was pre-populated and this is what you're receiving. Do you need something else? So thanks. I appreciate that information.
Yeah, no, totally understand. And yeah, some time ago we would get just reams of pages that just weren't necessary. So, trying to keep it clear and concise is helpful. I think we frustrate sometimes the hospital case manager a bit, when we don't get it and they think, well, okay, they're holding a bed. We're actually not. We've moved on to the next referral until we get everything, and so that I think leads to some miscommunication. But anyhow,
No, I hear you there. And again, I appreciate that information. We'll continue to work with our teams. I think we have pretty open communication. One other thing from your perspective, Bob, relative to these transitions of care, clean handoff, hard handoff, and what that means, I think we're aware. The other thing that has been a little bit of a burr, and what we're recognizing, because I'm a bit of a deep diver when, these opportunities arise, I'm like, what is causing this? We send the referral where we don't batch, because that, to your point, confuses, confounds, muddies the waters. It's patient choice. But then we're recognizing once we've sent the referral, we're waiting for quite a bit of time for the post-acute that we've referred to obtain the authorization from the payer. What has been your experience with, again, I get it. You need to have the authorization to accept and finally, fully take the patient. What are you experiencing with our payer partners in that realm?
To be quite transparent, honestly, we do really well with obtaining the authorizations from the MCOs pretty much same day. For some of the payers will take the patient without the authorization to expedite the referral on behalf of the hospital and the payer, and then circle back and obtain the authorization the next day or the next business day. That said, Gina, honestly, with some of the commercial payers and out-of-state payers, it's just a nightmare.
Yeah,
Trying
I
to
gotcha.
track down the authorization, and it's frustrating to us because, in some regards, college or North or whoever may want a patient, and we're working and sending email after email and calling just to get the auth. And from our perspective, obviously, costs the payer more. They're keeping the patient in the hospital longer, and the patient isn't getting to the appropriate level of care. That said, we see those slowdowns, and I'll be real frank about it. When we have new plans to the market and they're getting set up here relatively quickly, and you see that when, year over year when there's a new MAO coming to town, and it's like, okay, we need to sort this out, and on our
Yeah.
side too is obviously the training of the SNF admissions folks. We have a phenomenal amount of different payers, and they all have their own different approach. But for the vast
Yeah, but
majority of them, and Medicaid managed care MCOs, they pretty much move on a dime. It's new payers to the market, and I think commercial plans where we get kind of hung up. And I would like to kind of open that up for other SNFs to kind of comment upon.
I'd appreciate it. And from my perspective, you're spot on. I call it the maze that we operate through, being an acute or a post-acute. Middle of last year, I ran a big gap analysis. Long and short, after all of that operation, we developed what we're referring to as our global resource list. It was implemented, and it addresses who's on first, simply. Who are we to reach out to? Who are our contacts? Who the major payer is, the product under that payer, and the delegated entity that oversees these activities for those products for those major payers. We are already, after about 6 months, on version 33. That will be a testament to how much change is going on. So I commiserate with your pain on that. And it's been a labor of love with this, but it has helped us. Relative to some bandwidth. And yeah, I'd love to hear from the other skilled facilities as well, relative to authorizations, because I think from an acute side, we've submitted, we're waiting to hear back from our post-acute partners on, have you obtained that auth? Do you have that auth? We're experiencing some delays there. And we've implemented a protocol where if we haven't heard back, so I'm sure, bless you, Bob, I mean it, we bother y'all as much as you think you bother us. We're reaching out within 24 hours and calling the post-acute that we've sent the referral to, asking, have you obtained the authorization? And or have you submitted it, excuse me. And if they say, yes, we have, we're waiting to hear back, then we call the payer contact and we're like, you received this authorization, are you acting on it? And you're right, it's a lot of activity on our part relative to, some of these opportunities. So thanks. I appreciate your time, Bob.
Thank
All
you.
right, we have some comments in the chat. Thank you both for your feedback. That's very helpful. So Donna Thorson, who is with CoMagine Health, which is our state acute QIO, said that there's a list of data elements through Interact that might be a helpful foundation for developing a standardized list of what information in any hospital to SNF and SNF to hospital, and those resources are free. We had Lori. Oh, okay. Jen also said that there are huge delays with payers in obtaining of coverage for authorization on weekends. And that was actually one of the common challenges, was poor timing of, I'm sorry. Okay, yeah, poor timing of transfer between sender and receiver was a challenge for both. If things are occurring on the may cause delays for both hospitals and SNFs to receive patients there, based on the information we received from you all. Terry Lynn, your hand, and then let me see who the other hand is raised.
Thanks,
After her,
Kamisha.
we'll have Teresa.
Yeah, I just came on this call late. I just got off a call that actually really involved a discharge and admissions of patients with MDROs. But I just wanted to mention one thing. I got on this call late. There's so many logistics, so many issues to accepting a new patient or resident, either, post-acute or acute or whatever. But my concern is the facilities. I've worked a lot with the LTACs in Southern Nevada. And what they are saying is that they flat out have a list of post-acute facilities that just absolutely is no. It's not patient to patient. It's not, the criteria is not met with insurance. It's not about beds. It's just strictly no. And I have a list that was put together, provided from some of the hospitals that said the facilities will not accept certain kinds of patients, and one of them is the Canada Auris. So that was something I thought maybe we could address. Is strictly, it's not a case-to-case basis, but the facilities. I think that if we provide the right education, maybe that would help. But that just absolutely say no without even looking into the case.
Teresa, you want to come off mute and speak?
Sure. Can you hear me?
Yes, we hear you fine.
Okay. I just wanted to touch base on what Bob and Gina were talking about, and Harmon does handle all of the MCO's referrals for fundamental, and he mentioned something about if there was an incomplete packet, they would move on. And I think that sometimes we think they've had submitted for authorization. Is there a way to standardize the packet for what Harmon needs so there's no misconception that we've referred, we're waiting for an auth, but the auth hasn't gone in yet?
Sure. Happy to speak to that, and grateful for the comment. We do have what we call a clean packet guideline. It's no different than probably what the other SNFs are. We revamped it. I think it was with some help from the hospitals as well, to get it down to the minimum necessary for placement. And so, it has kind of the basics, the hospital phase sheet, the H&P, discharge summary, if needed, PT notes, OT notes, whatever. But we can obviously share that with the hospitals again, if that would be helpful.
It would be helpful, Bob. And one thing for the acute side is that once the doctor writes for a SNF evaluation, the next thing we know, the acute hospital is getting a SNF level of care approved. So we're trying to work this very rapidly so that we're not keeping their patient in the hospital getting a SNF level of care reimbursement.
Sure, understood.
So if we could streamline that, that would be great.
Bob and Teresa, I think I think overall that's a really good thing. I think we need to focus on maybe possibly having one that crosses all facilities, not just focusing on one facility type packet. Because I think that when we start individualizing things so much, that's when we start having problems, as we do have staff turnover, a very high staff turnover, particularly in skilled nursing facilities, and we have very individualized packets coming from different facilities. I think it does create more hardship. I think also at the skilled nursing level, they are very lower staffed than an acute care facility. And so going through all of those packets, like Bob said, they get 100 or so, a day. When they have one person that's doing admitting versus a whole case management team that's working on discharging, it is a lot harder to take that on. So I think it would be great if we could collaborate on getting what a good solid packet would be from an acute care facility, that a skilled nursing facility that is requirement for LTAC and skilled per se, so that when that handover is happening, everybody has the right information and everybody has the same platform to start from. I know coming from acute care previously, a lot of us, coming used to say, oh, well, they have access to our EMR system, or they, can look on the notes online. When you have so many different system processes, I think it just creates boundaries and it creates more issues, especially when we do see the turnover rate that we are actively seeing.
I think that's a great comment, Teresa. If it's worth it and others are interested, I'd be happy to push out our clean packet guideline, and maybe the group can kind of collaborate around what is needed and what's necessary, not necessary, and see if we can.
I think that's a great idea.
Before I do the questions in the chat, do we have anybody on the phone that needed comments? Or wanted to? So Gina, it is spot on the weekend concerns and payers and authorizations. They receive communication that they do not staff on the weekend. So they wouldn't even be able to get a authorization on the weekend because the payers aren't there. Marisa wanted to ask, what is regarding, understand why facilities are saying no to Candida auris. Is it a challenge to find a room? Is it education? Is it poor staffing, etc.? So if somebody from SNF or LTAC could come off mute and just kind of share what the challenges are with accepting a Candida auris patient, or if there is any challenge.
I just included a comment, Kamisha, and for the LTACs that I have visited, which are 5 of them, they all say that the concern is they don't want to take the residents because they'll tie up beds due to transmission-based precaution isolation. Now, that's why education is so important, because they can do enhanced barrier precautions now. They can put these residents together that have the colonized C. auris. But like I said, what's concerning is when there's a list of facilities that absolutely will not take C. auris under any conditions when they haven't even looked at it. That was my concern that I just wanted to address.
We do accept that diagnosis, and we have quite a few in our building. So I feel very qualified to speak to some of the concerns. And I think, there is isolation. Certainly we do put them together. I mean, obviously, if you're going to accept one, you're going to accept 2, and then you accept them hopefully 2 by 2 if you have semi-private, whatever. But there is a little more work to that, yes. As an example, to use the enhanced barrier, we do all of that, but it takes a lot of time. So if a staff person, for example, has a C. auris patient, it's taking them, each time they go in that room, they have to redress, use the PPE. There's an additional cost. There's a lot of time put into that patient. And honestly, there's no difference in reimbursement, which I believe there probably should be. At this point, it's just take them, and it does take a little more work, and we're certainly willing to do that. We've shown that in our numbers. So the other issue is the patient comes in usually with more than one C. auris, CRE. They're very compromised. So even if you got another C. auris as an example, I can't put them in from what I understand, in with the CRE C. auris. So then you're again limiting your beds. A lot of them are vent units, which is I need to fill those vent units. That's what they're there for. We end up losing those beds sometimes because of the C. auris. And so, I mean, there's a whole array of, doesn't mean people can't take them and do it. We've done it, and we've spoken to it, and we've been able to contain it and do the right thing, but it is a lot of work. And so I see why people are saying no, honestly, out there. But I mean, I think what we have to look at clearly is maybe some reimbursement for that work, because those of us that are taking them are putting that financial piece into it, are putting the clinical piece into it, and doing everything appropriate. And there's no difference for any of us. So I think there's a whole lot to be looking at that diagnosis that may not be going away for a while.
Thank you for that feedback. Rocky?
with Silver Hills and Silver Ridge. Yeah, Cioris, Terry knows, we have it in our buildings. And so I think for the buildings that have it, it's not so much an issue to admit if you can fill another bed that is open and you can cohort them. I totally understand why facilities that don't have it in their building would want to keep it out. So I think the best bet is probably to look for facilities that have it already in-house and then go from there. And it should be able to, smooth the process and get some admitted.
And
Rocky,
to add to that, Rocky, one thing, if you're not doing this, then, and a lot of facilities say, well, we don't have it, so we don't want, then you don't know what you don't have. And with as big of an outbreak as this is, all of the SNFs already have patients in there because if they're colonized and they've never been screened, then they have no signs and symptoms. That person could be in the facility and they could possibly be transmitting CRS because they're not under the proper precaution. So I know that's a problem that we've run into with trying to get facilities to do point prevalence screening so that you understand what you have, and then you can act appropriately based on that. But for, we have facilities feel that they don't because they haven't received a laboratory report for their patients, and that's, unless you screen, you don't know. The misconception we've run into in trying to get facilities to understand that, and that's why we encourage the screening. It's free. We can help you get the supplies so that you know what you have and what you you don't have. Wastewater surveillance from UNLV, and we had a lot of CRs found like in the Henderson, Boulder City area. But we may not have reports from those facilities, but it's in the water, so it's in the people. So we're currently working with facilities in those areas to do screening to kind of that are being identified water that they're doing surveillance on. If I have 4 hands up, but I know, so if you've spoken, if you could click the raise to speak. If you're talking, you're on mute, Donna.
Sorry.
There you go.
I just wanted to kind of highlight some of what I've heard about caring for CRS, and that you really do have to isolate the resident, which I know I'm talking about payment kind of things, and that shouldn't necessarily drive everything, but it does if you want to keep your doors open. But the patient has to be either with someone else who has the same condition or isolated. And then once they're no longer in that room, the room has to be remain unoccupied for almost 2 weeks in order to make sure that the disease, the fungus, is no longer there, is my understanding. And so that's a huge commitment on the part of the nursing home for caring for someone too. So I'm not sure. I think that that's the information that's been shared with me, but I just wanted to put that out there, that when we're talking about buildings being willing to take somebody with that infection, that it really is a big commitment on their part, also for the PPE costs. And so maybe something that needs to happen is a consideration where we have selected buildings that are dedicated to it, almost like what we tried to do with COVID when the pandemic first started, instead of trying to ask everyone to specialize and be able to know everything that they have to do to take it. It's just something to think about.
I wanted to mention though, it still comes down to a lot of education, which we're really diligently trying to do. You're familiar with enhanced barrier precautions, okay? Enhanced barrier precaution minimizes the amount of PPE that needs to be used. The doors don't have to be closed. The residents don't have to be isolated. They can do group activities with social distancing. There's a big difference between enhanced barrier precautions and contact precautions. And I just want to ensure that, that we're out there and we're educating these facilities because it is very different, and it really has helped to open the doors on admissions. So I just wanted to mention that.
Yeah, this is Bob. I just wanted to give a little bit of data to maybe help shed some light on it. And I agree with Donna and some of the comments that Julie made, especially trying to operate a SNF on a slim margin. To give you an example, we opened the day with approximately 48 referrals on the board. Of that 48, I would tell you that 25 of those patients were difficult patients to place. 4 of them required sitters. 17 required some type of isolation, and this was a little bit different. And we've seen the numbers change over probably the last, I don't know, maybe 9 months or so. A couple of the patients were L2Ks, 3 of the patients were respiratory. So of the 48, 25 were kind of difficult patients. And when searching for a fundamental SNF to place people, this is the start of the day, and we opened the day with 17 beds. So from a patient throughput perspective, we're going to try to move as much as we can, as quickly as we can, so that we can get to the turnaround by the end of the day and look at the discharges and what more beds we can fill from the 3 o'clock to the 8 o'clock hour. That said, I think the other thing that would be helpful, when we're trying to coordinate patient movement, I think one of the SNFs brought up on the weekends, from acute to post-acute referral perspective, what would be helpful is if you could just name the case manager and give the phone number in the notes when you're sending the referral, because oftentimes the staff changes on the weekend in the acute setting from hospital to hospital, and so it's difficult to track down that person when you're trying to get a hold of them, especially if you have one of the 25 problematic patients that we're trying to sort out. Okay, is the patient still on a sitter today? It's Saturday, and we'd like to move the patient. Or, okay, was L2K DC'd? Is the patient still in isolation? And trying to get a status update from a case manager on the weekend is oftentimes problematic. So just a case manager name on the acute side and a note could be helpful.
Marisa, I saw your hand was up.
I just, and I put it in the chat, but I know Donna mentioned about keeping the room vacant for 14 days if you have a C-ORAS patient that's now discharged, which is a challenge for the skilled nursing facilities because they can't put a patient in there for 14 days. But just curious to know if this practice is different from the acute care hospital, and why is that?
This is not a standard practice. I mean, if you use EPA approved products against C-ORAS, you do not need to leave the room vacant for 2 weeks. That
Okay,
is not a
thanks.
CDC guideline.
I didn't think it was, but I didn't know why that would be in place for 14 days to keep that room vacant.
Nurse, it's Gina. I was just pulling up communication from Jennifer Archer. She's our regional director for our lab. And when this C-ORAS event first came about, we quickly realized opportunity to develop screening processes, protocols, et cetera. And one thing that does impact the acute setting when we're testing is that it can take up to a week to get results back. And that's pretty snarly when you're looking at a rapid paced in and out, hopefully acute setting where you're trying to move these patients and I'm not sure at what level or to whom, any type of support can be provided to the acute relative to a quicker turnaround for our labs to get these results back. You know, we're tracking all of this in the acute setting. You know, again, we have the memorandum, the form, and our, you know, colonization testing instructions. So
What labs are you? Is this from state lab or your local lab?
let me open this up. I believe that we use a grouping. Hold on. I'm not that SME, that subject matter expert. Yeah, we're losing the state lab, it looks like.
Okay, and you said it's taking like 7 days to get results?
Yep, that's what Jennifer's been reporting.
So Gina, just a quick, this is Jen Connolly. I actually have a text from another facility down in Vegas as well regarding the lag time. Well, not necessarily in the state lab themselves, but in getting the results. A lot of acute care facilities are testing, are swabbing at the acute care level, but then that information is not being transferred to the skilled once it comes in. And because it was collected at an acute care level, the results only go to the acute care. And it is difficult to get those results on the back end to the skilled nursing facility. So then they wait, holding the patient with a potential swab pending on appropriate precautions to find out if they are active versus not, you know, so on and so forth, but they're not getting those results in a timely manner to then process them forward either off of isolation or into an appropriate area for cohorting. And so that's something that I think we also, you know, can focus on as well, is that turnaround time in that extenuation of results.
I agree. Definitely. And thanks for bringing that forth, Jennifer, because again, you don't know what you don't know. And so maybe as part of the referral packet, if it's been a screened patient that we're referring, we make sure, you know, we include results. But again, it's taken up to a week for us to get results. So.
And we can talk to the lab on that one, because it was my understanding that the turnaround was a lot quicker, like 24 to 48 hours, not 7 days. State lab team, you know, kind of what's going on with that, and do they see, you know, a quicker turnaround in the near future? Just to catch up on the notes in the chat regarding standard form of acceptance, it may also be helpful to understand what facilities are able to take IV patients, isolation, vent patients, etc. Gina mentioned that she says, I do know several years ago, the standardized packet list was provided, is what VHS used to embed the AI to select out of the EMR needed. Link for the interact form, and so that's accessible, and then we can also send that out for those that are on the phone and can't access that link. Code to a higher level of care to obtain an increase in reimbursement for the patients in isolation. From a SNF could answer that question. And I'll read it that are maybe on the phone. Can SNFs code to a higher level of care to obtain an increase in for patients in isolation?
A higher level of care is not required to take care of these residents.
So that means no, right?
Yeah, I mean, if they do not require a higher level of care for taking care of the patients that are on transmission-based precautions, including CORS. They do tie up rooms, and that's the issue. That's why we discussed enhanced barrier precautions. I do want to mention that also skilled nursing facilities being proactive and asking for the information up front. We have so many acute care hospitals in Southern Nevada that do PCR screening for CORS on admission. So they have those results available. And, you know, if you know that they screen on admission, ask for those results. And instead of waiting for testing again, I mean, they do have results. You have to ask for it and be proactive. They should supply it, yes. It should be provided. But for the hospitals that do screen on admission, that's available.
You know, this is Marisa. I just, I want to comment on the number of patients that we've been tracking every day, because hospitals report on this, with regards to patients that are medically cleared for post-acute, and we can't get them out. In the last probably 2 months, the number of those medically cleared patients that are ready to discharge has gone up from, we were tracking 450 to 550, and now it's pretty consistently 500 to 550 patients in the state that we can't get out to post-acute. So if you think about the number of beds those patients are taking up in an acute care hospital, that therefore now don't provide access to care to those patients coming in. And some of those patients sit in the ER for 2 to 4 days because we can't get them out to an acute care bed or get them upstairs. So just to give you an idea of what that looks like for the acute care hospitals, I mean, that's pretty profound. So I think that was another reason for us to try to want to work together to help with the situation, because it's not really, it's an injustice to the patient because they're really not where they need to be. And the longer they sit in our acute care hospitals, the higher the risk is for something else happening to them. So just wanted to share that with the group.
Thanks, Marisa. Misty from North Las Vegas Care Center shared that they have an older building. Their building is set up as Jack and Jill. 4 residents share 1 room. Of the 4, they are separated by gender. So they actually have only 5 isolation rooms in the building. It looks like you were typing and it stops there. So, it is difficult for us the space. And I know we with the Jack and Jill sharing 1 bathroom and exposure risk and things of that nature. So that is a hard, thing to figure out as far as space and making sure your residents are staying safe. I saw one about COVID. I can't find it. So if the person who typed about COVID could come off in that comment. I think it was saying facilities were with COVID, even though they were past the 10 days.
Yeah, that's me.
Here.
Kelly from Northern Nevada Health System. We're seeing that in the north. They're still requiring COVID beyond the 10 days quarantine period. We've got a couple of facilities up here that are still requiring it. And I wanted to just speak to Marisa's comment. We are doing an injustice to this patient. I always say length of stay is patient safety. So if they're in the hospital longer than they need be, then we're approaching and can approach harm. Secondly, where we see the most avoidable days from a skilled perspective for our patients up here in the north is the evaluating and the, waiting to get an answer whether or not the building has accepted the patient. So I just kind of wanted to understand what is it, because we do the same thing. We're part of the same system as Gina with Valley Health in the South. We're part of the same hospital system, and we have a canned packet that's very smart and provides, in my opinion, all the information that a skilled facility would need to be able to say yes or no. But we see sometimes 4 or 5 day delays in just even getting the yes or no, even before we proceed to authorization. And if it's one of the Medicare Advantage plans, we could be another 4 or 5 days out. So kind of wanted to get the perspective on the skilled facilities of what is the delay and the evaluation portion of this.
Are there any
Kelly, this is-
SNFs that? Oh, go ahead.
Sorry, this is Jen Connolly. Not that I work in a SNF, but I'm in them all the time. I would say from my perspective, from the outside looking in, being in these facilities, is their staffing the capabilities of them actually being able to review these packets and identify who is truly right for the facility or not, I think is our biggest struggle right now. Coming from the acute care side, where you think of ratios and what your nurses have in the facility, there is nothing like that in skilled. So you are lucky to have, you know, 1 or 2 nurses if you're lucky on the floor. And then if you do have an admissions person that is reading through these packets, like was said earlier, they're not necessarily clinical, so they put them to the side to then try to follow up with a higher level person to have the conversation, and that gets pushed off because they are constantly at the bedside doing patient care. In the skilled facilities, the DONs, the ADONs, if they have them, are doing bedside care. And so I think that that is our biggest struggle right now, is trying to get the people to even have eyes on these paperwork appropriately.
This is Marisa too. I think somebody mentioned earlier, some of the challenges is with getting authorization from the payer, it sounds like. And it used to be, or at least when I was in case management a while ago, and maybe this has changed, but it seems that the hospitals reach out to the payers to let them know that the patient is no longer meeting acute care and they need to go to a lower level of care. So is there a way where we could make that process more efficient? And I don't know if there's not, because obviously the skilled has to get authorization from the payer based on the facility being authorized to accept that patient. Whereas I guess in skilled, the case manager or whomever is reaching out to the payer to find out, to let them know that they're ready for a lower level of care. It's just more of a confirmation that the patient doesn't need acute care anymore. Am I right with that? And is there a way that we can work together to speed up that authorization?
Hey, Marissa, it's Gina. Not to jump in here, but I'm going to. Great question, and hear you. I'm going to forward you the global resource document version 33 that we've developed for VHS. I think it will provide some great insight, and I believe all our partners on this call, relative to the acute setting and the post-acute, are experiencing what I will stretch out on my limb and say seems to be some egregious behavior on the part of our payers relative to obtaining these authorizations. Yes, part of our protocol, our process for all of us in care management, discharge planning, we're communicating. Whether it's a skilled or an acute, we're communicating. You know, if a skilled reaches out, it's obvious it's a lower level of care. Some of these payer partners have quote unquote on-site care managers that are overseeing their patients. I just, in my mind, after all these years, have never seen the likes and am still trying to wrap my head around why it is so difficult to get an authorization. And it used to be these authorizations were difficult relative to a lateral LTAC type of transition. But now we're seeing it, and SNFs and home health care were kind of a slam dunk, but now we're seeing it in all post-acute venues. And it seems like just as you think you've implemented a strategy to counteract or improve, you know, the productive streamlined process of this, the payers throw something else. You're also spot on with quite a few of the payers will contract individually with their post-acutes. And so it is then beholden upon our acute and our skilled case managers to know, again, what I refer to as who's on first, who, you know, what we have to know for this payer, and this payer, what they're contracted with for this post-acute home health care, this skilled setting. So I'll shoot you that global resource that we use. It's pretty eye-opening.
Yeah, I think, Gina, I'd like to just jump in as well and provide some comments as it relates to that, because I feel like you're spot on here. You know, and I've seen this kind of over and over, especially with new plans to the market. And they kind of come in and then we're taking forever to get an authorization. You know, it needs to speed up. You know, that's one thing. And then, you know, the other thing is, you know, you have to use their network, and if you're not using their network, you're not going to get an authorization. And if the patient's requesting something outside the network, or the patient's clinical need is to go to a certain type of SNF that happens to be outside the network, then it doesn't even matter to get an authorization because now I got to go out of network and now I need to submit for an LOA to move the patient. And that is a different process. So then you're dealing with provider relations to try to get a an LOA for the patient to go. So yeah, it makes it difficult, and when we have new folks to the market, they're trying to set up shop, and typically this is where we feel it. Yeah.
And Bob, you bring up an excellent point respective to LOAs. I'm finding over the last year alone, our
Can you all please mute if you're not speaking? We hear some background noise of people chatting.
sorry, you have this uptick in the acutes engaging in LOAs that we're paying for to get these patients, moved and accepted because a payer hasn't engaged in an authorization.
This is Marisa again. I'm just wondering if there's a way to get around that. I mean, does the Insurance Commission have any authority over those types of practices that maybe it's just a lot with the commercial insurances? And how do we work together to speed that up? And then, do we just bombard the commission with complaints about a certain payer, and then how do we work with Medicaid too to help speed up that process? I know that, and I was talking to Sarah about this. She's our director of finance at NHA, but they have a process that they're working on, and they've only been doing this now for a couple months. And we're going to touch base with them again here, probably in the next week or two, but to see how that process is going. But they have developed some forms and some standardized processes to be able to reach out to the payers about some of the appeals that they're having to do, which it just seems like this is common practice. They hold on to, they don't authorize a patient moving to a lower level of care until the patient now is ready for discharge. And then with the process of appeals and that inefficiency that occurs with trying to get that process through the insurance company, and then the patient's ready to go, it's not really efficient. So we're working with the California Hospital Association to look at what processes they put in place to see how that's going now. And I know that they're working with their state division, and the insurance commissioner on coming together to make that a more efficient process. But, once we have asked them about that, we may look at implementing something similar here, but I'll keep everybody abreast of how that's going once we determine if that's helped them. But I'm just curious to see, that is so frustrating and so inefficient. In this time and day when we have such huge workforce shortages and we're constantly having to reach out to the payer to get authorization, to get them to pay, it just seems like it's so ridiculous. I don't know.
I agree with you, Marissa.
Yeah.
This is Bob. One of the approaches we took was, and a lot of the payers did come around and agree to, allow us to move the patients and get the auth after the fact and on the weekends. And if the patient has PASSAR and LOC, blah blah blah, obviously it's going to be skilled, or it's going to be long-term care, whatever. We can figure that out. But if you could at least get us to the next business day, that's really helpful. And I'm grateful for the 4 plans that are doing that for us now, because it would be that much more difficult, and we'd see a much bigger log jam, if you will, with referrals. I did want to make one comment, and I'm going to have to step off a little bit early, but I think the other thing that makes moving patients expeditiously is the availability of post-acute transportation services. And it really is difficult, and it's a huge financial burden upon the SNFs as well. We hope that, for the most part, and we have transport guides set up for all of the admissions directors, that they should be using the health plan's medical benefit should they have a benefit for transportation. But that said, we really only have like 2 basic transport providers here. I mean, for the most part, when you're moving commercial patients, I'm not talking about Medicaid, but it's either going to be Life Trans or it's going to be GMT. And God forbid if you get behind on your bill, you're never going to get a transport. And that's just not acceptable. There needs to be more transport providers in the state to help us move our patients. And that's why we see patients coming in late in the night.
Mhm.
I would prefer to get the patient here in the daytime when the physician's here and rounding. We don't want them coming in at 7, 8 o'clock at night, especially for maybe more of the frail and elderly SNP patients. That's a difficult time for them to move that late. So if the earlier we can get the patient to the SNP, the better we are. And in my view, only having these 2 transport providers available for our SNFs and for the hospital, that needs to change. And that's a process that has to be addressed with the NTA, in my view.
This is
Marissa,
Marisa.
Gina,
Oh, go
I'd
ahead,
say
Gina.
you're spot on relative to engaging conversations with the Department of Insurance. I mean, I know during the COVID times, their director was beautifully participatory in discussions. And I think now's another point in time to engage with them, again, relative to these authorization needs and starting those conversations about, why is this happening? To Bob's point as well, for the Valley Health System, the middle of last year, our regional director, Steve Pizer, and I started down the pipeline of how do we mitigate some of this. And we have established monthly clinical JOCs, joint operating committees, with each and every individual payer group. It's been a heavy lift, but I think we have recognized, fast forward to now, some great benefit in this back and forth discussion from a clinical perspective. We review avoidable day reports, which includes the recording of delays in authorizations. Have we honestly gotten any movement from our, I will say, payer partners relative to mitigation of these delays in authorization? No. But we'll keep up that good fight there.
Just a comment with regards to what Bob just said. I mean, I think the patient arriving late at a skilled nursing facility, I mean, he talked about the challenges that they have with that, but it's not necessarily the best in the patient's interest either, because they find that a lot more medical errors occur in patients that come into a skilled nursing facility late in the day because they don't have the resources, that they had during the day. So I think that is a challenge. But there again, if you have delays in picking up the patient, as far as transport, you're anticipating that patient's going to be transported that morning, and then they keep putting it off, and then they show up to take the patient to the skilled, at 7 o'clock at night. And I think it's important too, I mean, particularly if it's a Medicaid patient, that we have some documentation as far as the delays of that medical transport vehicle that they've authorized to come pick up the patients to transport them. I mean, perhaps they need to look at engaging another provider because maybe that one provider cannot handle all that volume. I mean, I think that's important. We need to go back with some data to Medicaid to say, this is the delay that's occurring in these transports. And as a result of that, should you consider adding on another transport company?
Yeah, Marissa, I would just say, even if you've gotten acceptance of a packet early in the day, and we know where the patient's going to go, and you call one of the commercial transport providers and you say, okay, I have a patient coming. What's the next available? Okay, yeah, we'll see you at 5:30, 6:30, 7:30, 8:30. You know, a lot of them are doing a whole bunch of dialysis runs that happen early in the morning. All of that is like 6 o'clock, 7 o'clock, 8 o'clock. But it seems like that's routinely what you get. You know, when you're using the state broker and their network, that seems to work fairly smoothly. But conversely, on these other ones that have a managed care medical benefit, it does not.
Yeah, that's good to know that that a lot of times this happens with the MCOs.
Okay, Chad Simmons, can you come off mute? I see your hand is raised.
Yeah, hi. Yeah, this is Chad. I'm with NewGen Healthcare. I just wanted to make a couple of comments because I work in multiple markets, not just in Nevada. We're seeing this as an issue pretty much across the board in other states where we operate. And I just wanted to comment on a couple of things. Somebody had made the comment about staff in the nursing facilities not being available to review the charts, to look at the clinicals, and that's not been our experience in any of our centers. I don't think it's from us. It's not a matter of us having the time to review or the staff available to review the clinical part. But it comes to the insurance companies, when we submit those authorization, it's a time factor. And I think some of this has to do with their ability to staff their own services at the insurance provider. You know, I talked to one of my centers this morning about their admissions today. They told me they had 5 auths pending, some of those since Wednesday. Today is Friday. If we don't get those authorizations back today, those patients are going to sit in the hospital over the weekend because they're not going to provide authorization on the weekend. And when Monday comes and they pick up those cases finally, I can tell you already what's going to happen is the case manager is going to reach back out to us and say the clinical information you provided is old and outdated. We need updated notes. So then we're reaching back out to the hospital saying, can you give us an updated therapy notes for the rehab on this patient so we can submit them to get the auth? And the process just gets dragged out because the providers aren't assigning people to review those cases when we're submitting for auth. So I think there's a huge lag time caused by the providers themselves. And I'm not sure what their motivation for that is, or if it's just because they don't have the staff to look at the volume and handle the volume of requests that they're getting.
Yeah.
For that
You know, just
feedback,
like the
Chad.
hospitals too. I mean, they have to go through travel agencies to hire staff. I mean, I think payers should be made to staff up to speed up that process too. I mean, why are they not held accountable?
Right, and then it comes back to when we do resubmit those notes to your comments earlier, then they're saying, well, we're going to have to do a peer-to-peer because we don't, agree that this patient necessarily needs skilled services. But had they provided that authorization, on Wednesday instead of Monday of next week, we probably would have been able to get that patient in, had them evaluated, started treatment, and probably they would be ready for discharge by next Wednesday. It's the time is just crazy that we sit and wait for them to respond. Honestly, that's a big part of it. So, I mean, if there's conversations taking place with the insurance commissioners, I mean, that's something I think that needs to be addressed with them as well.
Yeah, good point.
In the chat, we have Kelly said, yes, they do. They have to accept the patient and then skill has to get the authorization. Julie said that taking care doesn't take more care, but many more supplies and bed availability. Jen said that there are tools for auth such as Ability. However, when payers are not staffed on weekends, it causes further delays. And just agreeing with Bob. Tony said we have had some success obtaining auth from difficult payers working with Renown. Called and escalated conversations with the insurance companies to expedite the process, and however, that is also time consuming SNF as well as the acute staff.
Sorry, it's Marisa. This is just a thought with regards to the payers, but
I'm sorry,
mean-
I this whole time and was on mute. Go ahead, Marisa. I will start over when you finish.
I was gonna say, you know, I don't know if the insurance commissioner would be open to, or maybe, you know, I'm just thinking how we can communicate to the payers as a whole to work through some of the issues that we're having with them. I mean, I don't know if it's feasible to invite them to this meeting or to have a separate conversation with the insurance commission and the payers if we submit to the insurance commission some of the issues that we're having. And I mean, I don't know, just a thought I'm throwing out there. I'm trying to figure it out, but.
I was,
Marissa, sorry, it's Gina. I vote,
okay, Gina.
yeah, to have the discussion with the insurance commissioners. And the reason I see that, and I may be wrong, is that I believe for a while, just like these clinical JOCs we've established, they're going on 8 months, give or take. We still feel like relative to, well, I'll just put it out there. It's almost like they operate in some silos with their departments relative to who provides these authorizations, who we reach out to. This will make more sense when you take a look at that global resource I provided you. But I still feel like, you know what, we're done. We need to elevate this. And really have some meaningful conversation. I refer to it as exploration and discovery. I also think that relative to our partners, and they are our partners in the payer industry that we work with day in and day out, you know, they may not be in a position to affect cause beyond what their normal standard and practices are relative to providing an authorization. They're doing what they're told, and they're being provided what they need to do via protocol and policy. And I could go on, but that's just my opinion there.
Yeah, so let me try these comments in the chat again. So Donna said there may not be enough staff in the ready for discharge. Just because there is a bed doesn't mean that there's staff. Julie from College Park said that taking care of the patient, more care and bed availability. Jen said that there are tools for off such as, however, when payers are not staffed on weekends, it causes further delay. And Tom, they have had some success with obtaining authorization from difficult payers working with Renown. They have called an S to expedite the process. However, this is also time consuming for both us at the as well as the acute staff. Bina said that we need to address appropriate reimbursement for CR's patients in a SNF. In addition, we have limited beds for. If we have to have those beds tied up for a long time, it is just not feasible for a SNF for a long period of time without the appropriate reimbursement. They admit patients 24/7. They have to receive patients at 1 a.m., which is not good for the patient. Terry Lynn, CRs is not different from other MDROs like CRE, colonized residents. Residents that are MDROs can be placed on enhanced barrier precautions per CDC, which is a step down from contact precautions. And then mentioned that she agrees with Gina. They have a payer too, and made little progress. One payer specifically refused to participate in a JOC meeting.
You know, that the problem is the payer doesn't have any skin in the game, right? I mean, it costs them less to keep the patient in acute care, even though they need post-acute care. So somehow they need to have some skin in the game.
I agree. This is Gina again. You nailed it for me, Marissa, and I agree with Jen Bustamani's earlier comment that I saw relative to availability in these portals. I'm finding very quickly a lot of the insurance industry organizations are subscribing to these quote unquote portals where we're being told we now have to go to obtain the current status or state of an authorization. These portals are arduous at best to navigate, especially when these are fast running care managers, nurses, whatever, to sit down, access a portal, figure out how to navigate it, even with the instructions, and see where we're at with that authorization. So again, another element of time constraint on the part of our teams with obtaining that authorization. And we've been clear, to her point, it was like pulling teeth to get our payers to agree to these clinical JOCs. But we did it and we're still going to do it. Additionally, relative to authorizations, when we keep asking, well, we don't have it, where to go to the portal. Well, we went to the portal and there's been no movement in the portal. Can you help us? Well, contact this person. And then 2 weeks later, that person changes.
Oh,
Hence version 33 on the global.
that is so frustrating.
It is. So that's why I commented earlier about, I think we need to elevate to whomever, can maybe work to help get us some clearer movement.
Are
on
there
this.
particular payers, Gina, that you're seeing that are doing this, or is it pretty much all the payers? Or, I mean, is Medicaid doing that too? I don't think that they would be, but.
I will say to some degree, it's pretty much all of them. To Bob's earlier point and to Chad's, some of the payer groups are a little cleaner, a little quicker relative to providing us information and engaging in meaningful operations. But we, with straight Medicare fee-for-service Medicaid, we're finding it's not quite as difficult. But and again, when they've spoken to staffing constraints, I believe those organizations, that could be a definite, reason if there are delays in authorizations. But payer, whether it's MCOs, managed Medicare, commercials, managed Medicaid, it's across the board.
Wow.
And just as a sidebar, when I monthly look at our avoidable day reports and aggregate the data, that since last year has been the top indicator for delays in transition of care. No authorization or delays in authorization.
Okay, good to know.
So we are at it's left in the meeting. The next item on our agenda is to identify root causes of and solutions to inadequate. Feel we've discussed some of that, especially with the payers and the patients out of the facility and getting the authorization for a SNF to receive them. Also the concerns with CRs patients picking up the rooms for isolation, PPE needed to work with these, and concerns with reimbursement. Just some of the common things. Oh, then also Bob mentioned the transport providers that, they may have the authorization early in the morning, but they still won't receive the patient. Which isn't good for the patient. And then also, the physician on for the day, so they're not there to assess the patient. So we are planning to have these calls regularly, excuse me. So I know we probably can't get into all of that right now with only 30 minutes left. But I did want to discuss the transfer form that we had, because that's something that we developed years ago, pre-COVID, so long ago. And so I wanted to get your input. You should be able to see that screen that I'm. Yeah, so that's majority of the form. One opinion, I guess, that I received was that information for maybe like the bedside information, send it to LTAC or SNF from or discharging the patient to. So if there were items make it more comprehensive and easy to fill out, what would be information that could form shorter and maybe for like the bedside nurse or, excuse me, case management? I'm not sure. And then we say that who would this form out, because that was kind of a challenge for facilities to determine who would need to fill this form out or who would be appropriate to fill it out. And then it just kind of got stuck there with, you know, well, we couldn't figure out who would fill it out. And so it never, similar, that, yes?
I apologize, truly, it's Gina. This is, in my opinion, very important relative to final decision making. You keep cutting out quite a bit, and I'm a listener, and I'm not hearing a good bit of what you're saying, number one. I'd like to ask, if it's not too difficult, a proposal relative to sending this form. I'd like to really look at it closely and provide some commentary. Additionally, I will say, I'm sure there was a great deal of, limited response relative to who's going to complete this. And I don't want to speak for all the partners on this call, but I'm going to tell you right now, we're all strapped for staffing. And when I look at even a one-page document with all this information that needs to be completed, and I consider all of our teams and staff, to complete something like this, while I greatly appreciate the benefit and the meaningfulness, I'm like, wow, another form for my teams to have to fill out and complete. So I guess what I'm saying, though, is that to better be prepared for myself in guiding the teams, I'd like to understand, and I may be lagging behind, what the purpose of this would be, what the workflow or cadence would be, who's it coming from, going to, is that too much of a demand on my part?
Oh, can you guys hear me okay?
Oh, there you are, Kamisha. Go for it.
So the form was developed because in the past, this Jen years ago, communication has always been an issue. So facilities requested like a one pager with the person would need in order to receive a patient, to make sure that they could provide the services needed. So we worked with nurses and other hospital healthcare personnel to develop this form and the information that they would need. As I mentioned, like at this time, there was no staffing shortage. So of course, need and the ability to complete this form have changed. So that was the purpose of putting the form up, to see, using it, what can be removed to make this form more simplistic, and who would be most appropriate to fill the form out. Jen, I think you had something to say.
I did. Thanks, Kamisha. Gina, I completely agree that, we need to streamline whatever process that we do. This form is a best practice from the CDC, and we actually did tailor it down to one page because the CDC's version is two. And this, like Kamisha said, we did this, I want to say like 7 or 8 years ago, and we've added to it, obviously, to include COVID and CRS and such. The biggest thing that we are hearing from the skilled side, and I think Bob touched on it earlier, is that packet at the beginning, when that first form comes over to get acceptance from an acute care facility, the skilled facilities really need to identify what type of room to place a patient in, what type of staffing and other requirements such as PPE or things like that would need to be engaged to accept that patient. And when they don't know about any MDROs or minimally know about MDROs or other scenarios that would hinder where they place a patient, it then throws them off on that acceptance. So if they accept a patient, but they had originally planned on putting them in a double occupancy room, and then identify later on that know they are pending CRS, that changes their whole game plan on where they can place the patient, and then therefore changes the acceptance probability based off of what rooms or staffing availability they have, which then pushes it back to the hospital to start from square one yet again, which then pushes us into a Friday afternoon with no acceptance and a patient still sitting in an acute care bed when they could have been discharged 3 or 4 days earlier. So we're trying to get something to where, and it's not just MDROs, there's obviously a whole packet associated with everything to a patient care, you know, what type of devices they may have, what their sitter status is, like Bob said, do they require a sitter, not require a sitter? All of those pieces are extremely important, but trying to make it to where it is the easiest packet to read through to be able to identify the appropriateness of the patient in the facility that would be accepting, so that they can accept in a upfront knowledge manner, without wondering what's going to come on handoff at the very end. And I think that's where our biggest problem is. We get a soft acceptance or an acceptance, and they start to move forward, and then they find out more information about the patient, and then we end up stopping and saying, no, we can't accept the patient. And that's just not good practice for the patient care.
Thank you. I would agree. I think in the acute setting, though, what we experience is an extremely dynamic hour-by-hour change. So what we would, for example, document on this form may change in 2 hours. I'm also trying to, I appreciate it, don't get me wrong here, but I'm trying to realize how with already pre-developed automated packets that provide information relative to the referral packet in our system that's sent through CarePort, I'm trying to visualize how, while I see this as a great one-stop shop for this information versus navigating through several pages of document to find it, I'm still trying to realize how would I take this? How would AI automatically record this information? And then how would this be included, which that's actually the easier part, in the packet that goes to the post-acute. So I appreciate your information, and obviously for VHS, this, you know, again, I'd like to look at it in some vetting with our nursing partners, the care management teams, and our executive leaders would need to occur.
Gina, a question for you. Do all acute care hospitals have that same AI platform, or is it hit or miss based off of the corporate provider over that acute care hospital?
It's a great question, and I would have to lean on those partners to answer for that. I do know CarePort is the platform and application that we use. It is a organizational type of platform. Again, it's our corporate partners, but we have a great deal of ability through contracting to amend as we need to. Hence the reaching out a while back, I mean, it's probably needed again, and asking the skilled facilities to individually provide what they wanted in their packets. And then these were built within CarePort. So for example, if we're referring to Bob's team at Harmon, we have a list of what they need, and the artificial intelligence automatically will populate that packet with those elements out of the EMR. Additionally, information, when I talk about the artificial intelligence, it can also take documentation within our EMR of the same nature. Like, for example, COVID-19, have they had their first, second, and boosters? And it'll pre-populate onto a form like this, that information. So we're avoiding duplicitous work. Hope that helps.
It does. It does, definitely. I think that there are so many different versions of what every facility can self-populate like that it creates some difficulty on the accepting facility side as well.
I would agree there. But that's why for VHS, I'd like to take a look and do some exploring and discovering on how we can look to accommodate and include, while not duplicating work on the part of our teams, as best we can.
Appreciate that, and definitely, you know, cause more work, especially with the shortages. But just want to make sure everybody is getting the information. That a couple of hands raised. Teresa, you.
Hi, yes. So I appreciate this great discussion today. There is a process that nobody's touched on yet. And when we have patients who have Medicare only, they have full skill days, they don't have SNF benefit, or I'm sorry, they don't have a Medicaid application secondary. Sometimes we're hearing from the skilled facilities that they're not accepting the patient. And I got to tell you, I can't say as I blame them, because the Medicaid process is taken well beyond 3 months to get a patient approved for Medicaid. Those patients end up sitting in our hospital, even though they have full Medicare days at a SNF level of care. If we're truly going to be partners here, maybe we need to bring Medicaid in and say we need help in processing these secondary applications, both for the SNF and the acute. I think it would be beneficial. Thank you.
Thank you, Teresa. I believe we received that feedback from a SNF that we talked to, that, you know, we had Medicaid and they weren't a Medicaid facility, they couldn't take that patient. So it wasn't, you know, a CR's thing. It was that, you know, if they take that patient, they're not going to get paid. So that definitely is a challenge that hopefully we can look into. Marisa, Eileen, thing. If you wanted to come off mute to speak.
Oh, hi. Oh, sorry.
Marissa, you're on mute.
Yeah, Marisa, we can't hear you.
Oh, there. Okay, I thought I came off mute. I'm sorry. Just want to bring up another concern with regards to communication and this transfer form. I mean, I think we need to keep in mind too the transport folks, because sometimes they aren't aware of infectious things that perhaps the patient has. And so I think this transfer form or some sort of communication that you put on top of the chart or somehow notify them, other than, because communication gets missed sometimes depending on who's giving the report to the transport people. You know, they sometimes aren't aware either. So then they are at risk for contracting infections too. Just want to bring that up.
Marissa, you were spot on there. And back to kind of Gina's question about the form, the form wasn't just for acute care facilities to fill this form out. It would go both ways. So as a pulse is always required to send a patient, you know, back, that would be placed with the pulse so that the transport crew would know if there's anything. But then also when the patient is accepted to the ER, because we know a lot of hard handoffs aren't done, going from a skilled facility level to an acute care level, that form would also be helpful for identifying if a patient needs to be on isolation in the emergency department as well.
$15 minutes left. Does this time and on Fridays work for everybody to attend another meeting to further discuss these issues? And really, I would say looking at the issues that, how we can resolve these issues, or how mentioned, one of the comments in the chat said that Aetna and Anthem were the most difficult insurance providers. So I'm not sure from how we would go about those calls, but Marisa, maybe you know, or I could reach out to see who we can do on that level and voice some of these concerns and maybe find a solution on that level. I know there was mention of finding a standardized form. And then Gina, I will get your email address from Marisa to send you the transfer form if anybody else would like to look at it, so that we can have your feedback for the next meeting. I'll put my email address in the chat for those on Teams, and then for those on the call, you can email Marisa, which I'm sure I'll have her information, or you can email me at kcaui, so KCAUI at health.gov. So kcaui at health.mv.gov, and I'll also put that in the chat. So if you want to get the put the link for our HAI website. It's also posted there. So, and then that can be another discussion that we have on the next call. But for our next meeting, before everybody been on for a while, I'm looking, so maybe March, but a month from today, the 24th or March 17th, same time to 12:30. Does that work for everybody?
Hey, Kamisha, while
put to-
people are looking at their calendars, I think it's important that we document what some of the issues are that were identified, and then what you and I can do about some of those issues, what follow-up we're going to do to bring back to the meeting next time. And then therefore, I think it would provide people with an opportunity to look at some of those issues and come up with some solutions. I know for me, we have Sarah Hunt, who's in our office, and she works a lot with Medicaid and the payers. And I'm going to go to her with some of these issues about the payers to see if she might have any suggestions or contacts that perhaps we could reach out to communicate some of the things that we're hearing, and perhaps how we can move forward with them to come up with some solutions on their side. Oh.
For me, like I mentioned, I can reach out to Julia, who is our deputy administrator. She pretty much knows everybody. So she can assist me. I'll present the issues that I have written down, and we can speak to on those levels and express those concerns to, and try to find a resolution, for those issues. And, what we can do to move forward.
Hey, Kamisha, the 17th works better for me. The 24th, I think Renown has that transfer medicine update symposium that a lot of the rural hospitals participate in. And that's identifying some challenges and working through some of the solutions with the rural hospitals to transfer patients into Reno.
Okay. So next meeting, I saw somebody else put the 17th. Both days are free in my my calendar, but definitely if there's a meeting on the 24th. So we will March 17th and get an invite sent out to everybody for that. And then that meeting will also be recorded, because I saw somebody said the 24th works better for them. So I'll find HAI website so that we can get the meeting posted, and then I'll send the link out to Brett and to Marisa, email things. So those who weren't able to attend can listen to the recording. Vivian said we are using helps both ends. Oh, Gina, I know I'm familiar with the end of your email address, so I corrected it for you. No problem. I was like, ew, and I was like, oh, okay. It's supposed to. Let me pull the agenda back up. Were there any other comments that anybody wanted to make? We're at 12:21. Say this has been a great meeting. Oops, there it is. And I just really appreciate everyone's participation and transparency with the challenges you face, issues that you've identified on your side as well as on the other, so that we can work out some solutions. I would have never thought about payers being an issue, but that seems to be an issue for everybody. So this is very enlightening for me, because I'm not the boots on the ground clinical, So you guys really helped things that we can do. I am reviewing trainings that CDC has to put together a training on CR. So there are state data, of course, and what we've seen here over the last 2 years as in regards to CRs, and there's kind of just a back to basics going over PPE and utilizing the expertise of our IPs versus contact precautions and when it's appropriate to use one versus the they are chains of transmission and other conversations. So more to come on that. I might have more developed by March 17th. I might not, but hopefully, and this will be an in-person training. Ours are easy, but if you're like me, you get distracted when you are not the. So just make sure we attain everybody's attention. Also offering CEUs, nursing, and long-term care will be offered together. I will let you guys know so you can participate in that. If there are other training needs, my email in the chat. Let me do that now. But we do have funding to develop trainings, webinar, as well as person. We in the past hosted a all-day training South, and we connected through video conferencing. So there will be speakers live in the North, speakers live in the South. We provided lunch and breakfast, I believe. It was an all-day thing, and it was to that as well. So if there's training time, start working on developing our agenda for that training. 6 minutes left. Is there anything else? Anybody who would like to come off mute and speak? Alrighty. Well, thank you, Marisa and Brett and Pat, for helping to put all of this together. I think we got up to about 81 participants, which for a first meeting, I think was very good. To speaking with you all next month, and have a great weekend.
Thanks so much, Kamisha.
Thank you. Have a great day.
Bye, everyone. Enjoy your weekend.
Thank you.